today we're going to go on a journey all the way up to far north Queensland, where together we're going to solve a mystery disease that occurs in children in remote Indigenous communities. I want you to all grab out your phones, head online to polev.com/outbreak. No hints on what we're solving. Some of you might have the app, which you can just join anonymously with the tag outbreak. And we're going to give this a test run, and I'm crossing my fingers and toes this is going to work. So let's do a test run, and you can tell me how all you're feeling right now. Woohoo! One person has got it worked. A couple more people are confused. A few more feeling quite calm. Most people are feeling joyous, happy, excited, whatever that little emoji. A couple of people are feeling tired, maybe a late night last night. Maybe people are worse for wear after a few too many drinks last night. Awesome, guys. That's really encouraging that this platform works, and we're going to be using it throughout today's session. So we're all going to go on a virtual journey. We're all going to fly all the way up into the Cape. We're going to get in a plane here in Brisbane and go to Cairns. We're going to get in a smaller plane from Cairns right up into the Cape, into a small remote Indigenous community. In this community, there's about 1,000 people. There's one grocery shop, and groceries are delivered, including fresh fruit and veggies, once a week, which is the busiest day at the grocery shop. There's one little primary school with 2 teachers, one health centre, which has you, the visiting clinician, visiting every fortnight. Otherwise, it's manned by 2 nurses and 2 Indigenous health workers. In this community, 90% of residents identify as Aboriginal and Torres Strait Islander. There's 40% unemployment, and 50% of the community have only reached year 10. So you're really excited to be rocking up for this clinic for the next couple of weeks. And on your first day, a 6-year-old boy comes in with his auntie, and the auntie's a bit concerned because the kid's had some puffy eyes for the last couple of days. And it said his urine looks black. You take a sample and this is what it looks like. I haven't given you much, but what do you think's going on? You can free text into the poll. What are your differentials? What are you concerned about? What would you be concerned about in this community as opposed to working in a regional centre, in a metropolitan centre, or overseas? Post-strep GN, nephritis. I think it separates first and second words here. Nephrotic disease, PSGN. Lots of versions of post-strep GN. Any other differentials, or that's it? We're honing straight into what the problem is. HUS, HSP, great. Fantastic. You can see the predominant themes here are consistent across the room. We're all really concerned about acute post-strep glomerulonephritis. This is a downstream effect of exposure to a strep infection, be it in the throat or on the skin, as you all are probably most very familiar with. It commonly presents with edema, blood in the urine, hypertension. We're really concerned that kids with APS-GN can go on to develop hypertensive encephalopathy and acute kidney injury. There is emerging evidence to suggest that APS-GN in children goes on to confer increased risk of chronic kidney disease later in life. And this is incredibly common in the places that I live and work, in the Torres and Cape, and in other remote Indigenous communities across far north Queensland and Australia. So what's the diagnostic criteria for APS-GN? Everyone very quickly got the diagnosis. But what things do we need to check for to confirm that diagnosis? There's a few different options there, looking at physical symptoms. One person has no idea. Yeah, I totally agree. I have to get out the guideline every single time and check through the criteria because it is way too confusing. A couple more people think maybe it's the first or second option. There's a lot of ands there, a lot of ors. Most people in the room really just don't know. If any of those options are closest to the truth, it's probably the third option. APSGN is confirmed by both clinical and laboratory evidence. So your clinical evidence is 2 of the following 3 signs: hematuria on dipstick, elevated blood pressure for age, and facial or peripheral edema. You only need 2 out of those 3. However, for laboratory evidence, you need all 3. You need evidence of a recent group A strep infection. Now that might be by a culture of a skin or throat swab, or elevated ASOT or anti-DNAs. You also need microscopic hematuria and a decreased complement or C3 level. You need all 3, but you only need 2 out of the 3 clinical signs. So you're pretty sure that this little boy on your first day of your clinic has APSGN. You find that he has elevated blood pressure. You don't have any formal pathology on site. You have a little point of care machine and you see that he's got elevated creatinine. You're really worried about an acute kidney injury. So you task a retrieval. RFDS come a few hours later and pick up the kid and his auntie and take him 1,000 kilometres away, all the way to Cairns, where he's admitted to the peds ward for monitoring of his blood pressure and his kidney function. You think, whew, that was a busy day. And the health worker turns around and says, but we've now got to go and check out the house. She's like, what house? You read the guidelines and it says every case of APSGN needs contact tracing. The health worker knows this because the health worker's done this many times before. And so you and the health worker go to this kid's house, and this is what it looked like. It's got 3 bedrooms. The washing machine doesn't work. There's 8 adults, 6 kids, and over the last couple of weeks, there's been some sorry business. And they've had up to 15 visitors come and stay in the house at various times. So what does contact tracing look like for APSGN? Do you check everyone for sores? Check everyone for high blood pressure or blood in the urine? Or God forbid we actually have to contact trace for something other than COVID? You thought you'd never have to hear that word again. Okay, most of us in the audience want to check for sores. Great. Some people want to test for urine. A couple of people are going to measure some blood pressures. And other people just thought that contact tracing wasn't really required for anything other than COVID. That's great. So contact tracing involves screening everyone in the household that's been in there for the last 2 weeks, irrespective of their age. You're going to screen everyone for hypertension by checking their blood pressure. You're going to screen everyone's urine for hematuria, and you're going to check everyone in the house for scabies and sores. All kids in the household from 1 to 17 years will receive a long-acting penicillin injection. So there's at least 6 kids, if not more, that you're going to have to jab with penicillin because they were in the same house as someone who had APSGN. Of course, if you see sores or scabies in adults or anyone out of sight of that age bracket, you're going to treat those as well. This is a huge, huge day for you. You're pretty exhausted by the end of the day. You're glad that tomorrow's a fresh new day at the clinic. You can start to see other patients. A couple of days later, 3 more kids come in. They heard their little friend had gone down to Cairns. They also have got changes in the colour of their wee. And I don't know about you, but I'd start to feel a bit panicked. I'd be really concerned about an outbreak. There's no surprises to the talk today. This is talking about an outbreak. Has anyone in the audience here managed an outbreak of APSGM before? Woohoo, Ari. And just Ari. And me, Josh, you have? There's a few of us. I saw a little quiet hand at the back there. Not many. Does anyone know how we define an outbreak of APSGM? You didn't even know? Yeah, how crazy is that? Thank goodness we've got some really great national guidelines that you can quickly read through between patients. Yeah. So an outbreak is defined as 2 unrelated cases in a week or 3 unrelated cases in a month. So that's generally 2 or more households, because unrelated would be another that wasn't a close contact from the first case. So since these 3 other kids all lived up the street in different houses, and you confirmed that they weren't close contacts from the first case, we well and truly have an outbreak on our hands. So how are you going to manage this outbreak? Drink wine, call public health, look at the guidelines. That's a great start. This is a dry community. I don't know where you can find the grog. Maybe you've snuck some in for your 2-week stint here. Panic, yeah. Call in the protein node. Don't know if that was an autocorrect to something else. Put penicillin in the water. Yeah, probably could put a whole lot more in the water, couldn't we? Don't go call the PM. Wouldn't that be nice if we did have the attention from state and national representatives? Jab everyone with penicillin. Great. Lots of penicillins here. Great. Lots and lots of penicillin. Look up your notes from Don't Forget the Bibles. That's great. Scroll through your photos. Where was that one from that talk 3 years ago? Good job, guys. No, you don't manage it. You're the doctor on the ground. They're all looking for you and looking at you for guidance and direction. Post on social media. Oh, that's an interesting one. I'm not sure if it would be culturally appropriate to highlight a particular community. You can see that I haven't named a community here today, and we have to be very respectful of small populations of Indigenous people. So I'm not sure I'd be putting on social media just yet. These are all great suggestions. So what do the guidelines say? So an outbreak response is screening the whole community. Remember back to the demographics a few slides back? There are 1,000 people in the community. We need to screen all children between the ages of 1 and 17. In addition, there's a huge element of community education and advocacy that happens in partnership with council, elders, Indigenous healthcare workers, and often a fly-in team to provide additional support, because it's a huge body of work, and you and 2 nurses and 2 healthcare workers aren't going to be able to screen the number of children throughout the whole community. All kids between the ages of 1 and 17, you're going to screen them, or health workers, nurses, other community advocates are going to screen everyone for facial and peripheral edema, and if they find any, they're going to refer them on to the doctor to do a blood pressure, a urine dipstick, and a further assessment. Everyone's also going to be screened for scabies and sores. And unlike the close contacts, we're just going to treat those kids who have the scabies and sores rather than completely everyone in that household. So you probably might be wanting to put ivermectin in the water as well as the penicillin. This is a huge body of work that takes up the entire next year week. Everyone else has wiped off the books, and this is what you're focusing on. 400 kids are screened. 100 of those, so a quarter, have sores or scabies. You have never given as many penicillin jabs in the last week in your whole career. and a total of 10 kids are diagnosed with APS-GN. This is enormous, and you are exhausted. By the end of your stint there, you are so glad that you're getting on the plane, you're looking out the window at this view, you're leaving this community, and you're heading back to your comfy home, your comfortable lifestyle, your comfortable bed. But for this community, this happens every year. Across the Torres and Cape in the last decade, there has been at least one APS-GN outbreak a year. This is all too normal for Indigenous communities, when it absolutely should not be. The attention garnered with things such as COVID-19, monkeypox, JEV, just is incredible in comparison to significant health issues in remote Indigenous communities such as APS-GN. It is a disgrace. And to have people here in the audience who, it is okay not to know, that's why we're having discussions like this, but not to know this exists is shameful. And we have to do something about it. What do we do to prevent APS-GN? Josh, Vicky, others have spoken this week about the social determinants attached with acute rheumatic fever and RHD. This is the same. There's lots of attention nationally for RHD, but many of you didn't know about APS-GN. The same downstream effects of Group A strep and exposure to poor social determinants of health. Health hardware, such as taps not working, washing machines not working. In this case, the washing machine didn't work. The family had to once a week put all their washing in a basket, walk down the road to a family member's house and do the washing there. Overcrowding, improved housing, these are the primordial elements that we need to prevent. In addition, community awareness and education is important, but probably more importantly, education of health workers, such as yourself. The transient nature that we spoke about yesterday of health workforce into these communities means that even to this day, there are cases that are not diagnosed. A fortnight ago, I was notified of an APS-GN in the Torres and Cape, and that child had a delayed diagnosis of 10 days. They had seen a clinician, a doctor, 3 times in those 10 days, but it took 10 days to make the diagnosis because that clinician was a locum, hadn't worked in Indigenous communities before, and was just completely unaware that this should be on their radar as a differential. And then finally, early notification to public health to mount an appropriate and early public health response as required. You can see if it was just you and a couple of nurses and a couple of health workers in a community, screening a whole community is a huge event, and you need additional support. Interestingly, APS-GN is notifiable in the Northern Territory and in Western Australia. It's not notifiable here in Queensland. Despite a lot of advocacy, it is still not determined a priority by people in positions of power here in Brisbane, even though it is a significant issue for remote communities 2,000 kilometres away. So what can you do? Apart from leaving the session today being a little bit more aware of APS-GN, what it is, being interested in looking up the guidelines, having a bit more of a read, you can advocate for change at a number of different levels. You can advocate for change at primordial prevention level or at increased community education, awareness, healthcare professional awareness. But also we can all advocate for, at a start, APS-GN to be notifiable here in Queensland where it's a significant issue. Thanks so much, guys.
Fantastic. So we have some questions, but before we do, I just want to take you on a journey back half an hour to where I forgot one of the 2 jobs of a chair and didn't actually introduce Allison properly.
That's okay. I didn't introduce myself either.
You should tell the organisers.
Fortunately, 50% was the past market. Made it free. So Dr. Allison Hempenstall is a GP and public health trainee based on Thursday Island. So has a vast amount of experience in this area. Are there any questions from the audience? Wonderful.
Thanks. Hi, I'm Emma. I'm
Hello.
a paediatric emergency physician and I've recently moved to Townsville, so this is
Cool.
very much exactly what I need to know, and I haven't worked in remote or regional health before. I had a few questions. My first question was, using edema to screen, do you miss cases that have just the hematuria and hypertension?
Potentially you can. Josh, what do you think?
Yeah, absolutely. It's an imperfect screening tool for sure. But I think what tends to happen, like on the ground in primary healthcare, is it's not just about looking to see edema, fine, you're fine. It's the conversations around that as well.
And I think that's really in an outbreak setting response.
Yeah.
So anyone that comes into Townsville Emergency Department and has an elevated blood pressure because they've had that as triage, then you're going to look at the cutoff scores for their age and gender for their blood pressure, and then maybe that would prompt you to ask the family or look for edema and do a urine dipstick. Yep.
I think the other thing I'd add with that is that so you've got a public health response that's going to see all of these kids get benzathine penicillin, whether they've got edema, whether they've got PSGN or not. And in terms of turning off sort of treating the antigen that's driving this, that's sort of the crucial bit. And the screening by looking for edema, by thinking about blood pressures and hematuria, is really trying to make sure that you don't miss the kids who are going to need additional treatment to manage their nephritis and the associated hypertension, and be looking for those possible sort of more severe acute presentations with hypertensive encephalopathy and things as well. And I think the edema is probably a good way of looking for those kids while at the same time making sure that everyone's getting penicillin.
Okay, thank you. Do we know why people get, because post-strep glomerular nephritis, as far as I'm aware, is not actually a contagious disease itself, it's just a reaction to strep. So why do we get outbreaks? If there's no answer, that's fine.
So there's still, obviously evolving evidence in this area, but it's thought to have nephrotoxic strains of strep that circulate throughout a community, which then develop into an outbreak. And you're totally right, APS in itself is not infectious, it's an inflammatory response to strep, and we think that there are some strep strains that are more nephrotoxic.
Last question, I promise.
I was just going to jump in as well and say it's interesting because we had similar questions yesterday about rheumatic fever and rheumatic heart disease, and it does behave somewhat differently. So the phenomena of having clusters or outbreaks of post-strep GN is actually better recognised than getting clusters or outbreaks of acute rheumatic fever. And so this theory that isn't well proven, same sort of issues in terms of identifying the strep itself, because that's happened some time before in terms of triggering the immune response. But there's a pretty good indication that there are going to be nephrogenic, I can't think of the right word for it, but it's going to set off the immune response that drives PSGN, and probably related to one or two strains that are circulating.
Thank you. And very last question. In the ED, where I do see quite a few sort of high-risk children, I guess what can I do specifically for those kids? Like, should every kid that comes in with any kind of skin sore just get penicillin?
Yes?
Yeah, okay.
It is very different. You read ETG and it says sore throat. Do not give antibiotics in big bold. But there's a caveat to that. If you see any Indigenous child, and you'll probably have a lot that come across from palm, and there's a significant issue on palm at the moment with skin sores and scabies, you need to be giving them a penicillin jab or a short course of trimethoprim, which has been proven to be just as effective. So not trimethoprim, so cotrimoxazole or Bactrim. Yeah. Also might be helpful for you. We are in the process of publishing state guidelines, Queensland state guidelines for APS-GN. There are well-established guidelines from the NT and WA which you can use before those are released, hopefully by the end of the year.
Kia ora, my name's Helen, I'm from New Zealand, and I appreciate the talk today. We work very hard with gas in our community, particularly within our children. My question for you, which is part of what I'm currently working on and part of my learnings, is educating the health professionals, and that's one of the biggest things for us, particularly now we're getting our prescribing pharmacists on board. How do you promote it? How do you do it? How do you get people, apart from things like this, how do you get people to listen to your message?
That's a good question. I think you've got to attack it at multiple different levels, which ideally starts at medical school, doesn't it? Having a curriculum in Australia and New Zealand that covers Aboriginal, Torres Strait Islander and Maori health. And then additionally onto that, as trainees progress throughout their training journey, making sure it's part of the curriculum, and hopefully a trainee has a well-rounded training experience, which might include rural and remote health or Indigenous exposure to Indigenous health, and then coming to conferences such as this. I don't think there's a silver bullet in approaching this. You've got to target in lots of different approaches. There's on the ground community education that we do and then redo and then redo when we have health staff that there's a high turnover of. So quite often educating nursing staff, health workers, transient locum doctors that come through as well. It's an ongoing process.
Hi.
Fantastic. Yeah, there's a question there. Oh, sorry. You over there? Yeah.
Katie, pen physician. Is there any penicillin resistance, and what are we going to do if that happens?
I would say that strep is really effectively eradicated from penicillin. Obviously, there's MRSA, which we're concerned about, and there are huge rates on the Cape of up to 50% of MRSA for staph, not strep. But penicillin resistance for strep is not something that I've commonly come across.
It's actually never emerged globally, and so it probably won't, and something inherent about the bacteria itself. So there's a lot of problems with group A strep, but resistance isn't one of them.
Katie, also PEM physician. I'm just rethinking about giving these children, Indigenous children with sore throats in the emergency department oral antibiotics, and I'm just wondering whether a quick one-off dose of IM Ben-Pen might be better and more effective for compliance.
Yeah, I'd use the word adherence rather than compliance, which confers a paternalistic approach to how we deliver healthcare. And I would give the choice back to the clinician, which is the patient and their family. I know when I first moved to Thursday Island, it was like, oh, just give them a jab, just give them a jab, just give them a jab. And there may be some situations where you take a bit more of a social history and there's a very disruptive social environment, there's other factors at play which you may offer or advocate for a penicillin jab. But now that there is really robust evidence to support 3 days of Bactrim, I'll be putting the choice back into their hands.
You have a question over here. Over this way. That's all right. I'll go, Ari.
Thanks so much for your talk. I thought it was fantastic. I work in the west of Melbourne, in a really multicultural part of Melbourne, and we've seen this in Samoan families, and so I think this is really applicable to our areas where we work in really diverse and multicultural, where we have First Nation families from Tonga, Samoa, and broader. So I think this is super applicable. I just want to say thank you for raising our awareness and the knowledge around this. Thank you.
And it comes back to those social determinants, doesn't it? Those families may be experiencing overcrowding and socioeconomic disadvantage. Probably good to also spruik another guideline, the Healthy Skin Guidelines that you can find online by Asher Bowen et al. I'm sure you're one of the co-authors, no? And they're really fantastic, easy to use guidelines for the treatment of skin sores.
Am I allowed to ask a question?
Yeah, of course you can.
Yeah, thanks. Allison, I wanted to ask you about the kind of longer term sequelae. Like, I feel like in paediatrics, we see some of these diseases and it's shocking, and it becomes a big part of practice for paediatricians working in Northern Australia, definitely. Acute rheumatic fever, rheumatic heart disease, post-strep GN. But most of the kids with post-strep GN, even the ones who get really sick and occasionally end up in ICU with hypertensive encephalopathy or other problems, they get better. The acute rheumatic fever episodes get better. We see some awful outcomes of rheumatic heart disease, but actually most of the kids that we see who've got rheumatic heart disease who have had post-strep GN, we sort of graduate and transition and send them off when they're 17 or 18. And I think sometimes miss seeing what then the kind of flow-on effects are. But I just wonder, in your experience working across the age spectrum from the very youngest to the very oldest, like what do you see in terms of what plays out for kids, for instance, who've had repeated episodes of post-strep GN or even some of the rheumatic heart disease stuff as well?
I think there is a paucity of evidence for the long-term sequelae of PSGN. I often see kids who come back after an episode and they just have this persistent proteinuria. And you call the specialist and they just say, repeat in 6 weeks. And so you end up looking at a patient's chart and they have like literally 50 urine MCSs, all with proteinuria, elevated ACR. And no one knows what to do. It is highly likely, even though we don't have the evidence, that those children then go on to develop early chronic kidney disease. And there are some people that you see in their mid-20s or early 30s, and the records, our electronic medical record, doesn't go all the way back to when they were a child. But you think, why are they getting CKD so early? And yes, there is a myriad of factors, including hypertension, type 2 diabetes, obesity, a whole range of things. But I think exposure to diagnosed or undiagnosed repeated PSGN episodes puts them at greater risk of chronic kidney disease. There is a PhD or two in that.
Fantastic. Any other questions? There's just one comment on Twitter. Jordan Walters mentioned that Group A strep is still not a notifiable disease despite this. Should it be?
So invasive Group A strep is. So if you have a positive blood culture, then it is here in Queensland. I probably can't comment on other states. I'm not sure that all Group A strep infections need to be notified. That's a huge body of work, and what are we going to do from a public health response thereafter? But at least if there was, and we know that not all Group A strep are necessarily these dangerous nephrotoxic strains that go through and cause an APSGN outbreak. But if we were to at least notify one case of APSGN, then we can support contact tracing and hopefully prevent further APSGN cases in the community.
Wonderful, cool. Thank you very much. Can we have a round of applause for Dr. Allison Hempenstall.